Thanks, Professor Ines, for allowing me to be member of this very prestigious event. وبشكر سنوفي على ان هم دعوني ان انا اكون advocate لواحد من the first very important armamentarium members in the Egyptian market. Dear Professor Chairman, my talk will be about the art of control of diabetic patients and the core of primary prevention, and we have to get the clues early of the complications before the patients complain about them. My agenda will be, I try to be concise about, we will present a case of a new onset diabetes case with application of joint consensus statement presented excellently in a joint session between Professor Hassanin and Professor Ines yesterday. We will try to apply this lecture into the case and highlight the importance of early cardiovascular and renal protection in type 2 patients. This lady, Mrs. Sarah, is a female, 46 years, came complaining to the internal medicine clinic of polyuria, polydipsia, and continuous fatigue. This constellation of symptoms had bothered her because she has a family history, both maternal diabetes and paternal hypertension and ischemic heart disease. She was diagnosed 2 years earlier of grade 2 hypertension, 4 years earlier, and now she is on aspirin and low dose ARBs. Her on examination, she is on the verge of obesity, and her blood pressure is not controlled by the ARBs. Thanks God, her fundus is normal. When the lab are there, you can see that she is uncontrolled. There's in the on the online and here presenting, I think she is not. She has one of the complications, one or two of the complications. Do we agree on this? Let's see the hands up. Okay. So she's not, according to the cutoff points of the ADA, this patient is diabetic and she has an estimated GFR which is between 60 and 89 millis per minute, and this means she is diabetic kidney disease grade 2. Her LDL is out of the target for a type 2 diabetes patient with multiple risks, and she has an ejection fraction on the echo showing 55, which should have been 60. For every 1% increase and increment in the A1C, there are increment in all the complications, whether microvascular or microvascular, as we had known from the UKPTS. Complications range from low at 6% for the stroke up to 73 or 75% for the neuropathy. That's why key assessing patient characteristics are pivotal to get a diabetic care plan, and we have to emphasize lifestyle and others. Besides, we have to set the glycemic target for every patient according to many factors. That is the duration, the life expectancy, she's young, whether she has complications at this time of presentation, and later we have to set another glycemic target when she presents later on, maybe she developed complications later on. Please consider this slide as a clue for what will be next among the questions, لأنه هيبقى في questions على الحالة later on. Dyslipidemia promotes not only the cardiovascular disease but also diabetic nephropathy via the quantity, the number of the LDL and its quality. The glycation and the oxidation of LDL has a very important role in the exacerbation of the atherosclerosis and developing whether end-stage renal disease or cardiovascular events. And so what will be the goals of your treatment according to the consensus of EASD and ADA released earlier in September 2022? There are 4 main pillars, all equal, are very important. They are all to be tackled: the glycemic management, the weight reduction, the cardiovascular risk factors, and the cardiorenal protection. Don't wait till the patient develops symptoms. And so we have to go and consider the specific factors that are to be targeted, whether the A1C, work on the control, the side effects of the medications. We have to guard against hypoglycemia and ketoacidosis and events of hyperglycemia as well. And we have to consider the accessibility of the treatment. Sometimes drugs may not be available all the time in the market, and the cost, of course. Some drugs are marvelous, are wonderful on both glycemic control and weight reduction, and they have proven cardiovascular and renal protection, just as the GLP-1s, but their prices are challenging to most of the economies. I knew a piece of news just 1 second before I'm on stage that the US dollar is now for 22.7 Egyptian pounds, and this actually broke my heart. So we have to go and seek drugs that are very high quality with low cost acquisition, and their quality are guaranteed by pharmaceuticals that you are certain they will provide an equivalent brand like quality for our patients. So what are you going to do with this patient? This patient جت لحضراتكم في العيادة، هتدوها ايه؟ حد يقول لي اي حاجة طيب؟ نعم؟ Metformin, excellent. Actually, this goes with the guidelines of American Diabetes Association 2021 and 2022. Yes, metformin is generally the most and the first selected drug at the beginning of the diagnosis, but not necessarily the sole drug. We should have been assessing the patient in pillars according to the risk factors and assess if she has already established cardiovascular disease before or not, or if she has risk factors. Remember, this lady is overweight, she's dyslipidemic, on the target, she has family history of ischemic heart disease. Besides, her estimated GFR is below. Yet, she was given metformin. I'm sorry for the slides, but this is very common, this is very famous from the American Diabetes Association, stratifying the drugs according to their special characteristics in effects on the cardiovascular, heart failure, and renal outcomes. And it's clearly known that metformin, long ago, since the 50s and the 60s, and proven in the EcoBTS in the stringent control arm, that metformin has high efficacy and can control the patients. But if we look at the EASD plus EDA consensus, it's not only to be considered one item. We have to tackle every four of the pillars together. And so we should have selected some other thing, but actually what happened is that one of the colleagues had already chose to give metformin and gave her rosuvastatin. That was a wise choice, and she had been on metformin for 6 months. I wonder why he had left her for 6 months, but maybe he had considered her that she's newly onset diagnosis. Let's wait. What you can see from this lab, to myself, she's not controlled. Do you agree? Okay, definitely she's not controlled because still her target is above 7. And the estimated GFR declined down to 80, though we are still in the same level of diabetic kidney disease stage 2, yet it's declining. And LDL, though declined 90, yet in high-risk patients over 40 years of age, we should consider LDL down to 70 or even down. So what will be your treatment options? You have to add something to metformin. And among the choices, which is most commonly available, GLP-1, maybe she injectable and she refuses. I'm not that obese as my doctor, please don't give me an injectable. I'm already on metformin. Definitely the most common prescribed easiest drug in the Egyptian market with some prescription habit. Do you know what? الناس بتعمل ايه بعد الميتفورمين؟ DDP4s. Actually, not all the time. Okay, this is great. Okay, this patient was prone to this scenario, and she had been given DDP4s with metformin for 2 years. So over the time of 2 years, besides her ARBs and statins, she presented to the cardiology consultants who used to treat her father. Remember, her father was an hypertensive and ischemic. Why she presented to a cardiologist? Because she started to suffer chest pain, and she considered herself ischemic as her father. And please, doctor, would you allow me to have an elective PCI? I'm afraid about my heart. And so when her cardiologist looked at her lab, it showed clearly she's developing complications. She's not controlled, and this is a natural history of type 2 diabetes, by the way. She was taking the drugs. She was on excellent lifestyle and adherent to drugs, but the natural history of the disease maybe, and her estimated GFR declined down to 60, and we are on the verge of 3A chronic kidney disease. So this is a question for you. Which type of high-risk patient of risk patient do you consider this patient? A, B, or C? اللي بيقول A يرفع ايده. Okay, اللي بيقول B يرفع ايده. اللي بيقول C يرفع ايده. Okay, number A wins. Yes, she's a very high-risk cardiovascular risk patient. She has target organ damage. Yes, she has renal function issues, and besides, she has other risk factors regarding obesity and family history. Besides, she's developing chest pain. So adding other drugs that are known from the studies directly beneficial to the heart for back to 2021 بالمناسبة. This is not 2022 ones. So she had been given, she's the chronic kidney disease. What the drug of choice of chronic kidney disease? So estimated GFR over 20, SGL2 definitely. She's ischemic, and ejection fraction, you can remember, came 55. We don't know about the recent one, but actually I think it's maybe declining. So according to the recent 4 pillars of the EASD and ADA, she should be given SGL2 with its inhibitors with its proven cardiovascular and renal productivity, as long as the estimated GFR above 200 millis per minute. And to remember, according to the ADA and European and ESD consensus report that had been elaborately described yesterday, do you think SGL2 inhibitors are recommended for which patient type of those presented? Those with more for risk to minimize hypoglycemia and to improve their weight loss, or those with high risk cardiovascular or established cardiovascular, or patients with high risk or established cardiovascular disease? Which type of patients do you think SGL2 fit best? Excellent, all of the above. I'm very happy with this slide because I was doing the exams for the baccalaureate the last 2 weeks, so this was the same as what I'm doing. SGL2s, this had been shown earlier, very early, and be published in the European Society of Cardiology, that the benefits of SGL2s are not only metabolic, they are cardiovascular and renal as well. They decrease the enhance weight loss, and they decrease the plasma volume, so they improve the heart failure. They improve the erythropoietin and the oxygen delivery to the heart and to the brain. This is very important. Besides, it's decrease intracellular oxidative stress, and so benefits the kidneys and the hearts. And so that's why SGL2s had been upgraded from an intermediate drug level to intermediate to high drug level in 2022. Previously, it had been classified as an intermediate drug. Now, it's intermediate to high, and we can clearly see this, that SGL2s are now intermediate to high. They have no hypoglycemic side effects. Besides, they have weight loss effectivity moderate. So if added to metformin, this will be enhanced. Both the CANA and IMBA maybe have on the major adverse side effects, yet all three molecules of gliflozins are very beneficial in heart failure and for the progression and preventing the progression of diabetic kidney disease as well as chronic kidney disease of non-diabetic origin. Besides, they should be only stopped in dialysis. They are given orally, but we have to guard against ketoacidosis, and we have to warn our patients about the hypoglycemic symptoms and the ketoacidosis and hyperglycemia events. This had been presented in many conferences over the last 2 years, from 2019. This is the declared TIMI, which had been investigating over 17,000 patients and had been showing clearly that dapagliflozin benefits patients, not only those who have already cardiovascular events or have presented with symptoms, but those also who have just risk factors. Dapagliflozin was able to prevent up to 60% of the events marvelously, and to prevent hospitalization for heart failure by 17% in relation to placebo. And also it had been able to reduce cardiovascular risk and all-cause death in the presence and absence of heart failure reduced ejection fraction. It has been clearly able to decrease the renal composite outcome, whether it was death due to cardiovascular event in renal or in the stage renal disease or renal death. The same here, it has been shown clearly in the renal composite of some patients. Besides, in the DAPA heart failure trial, some patients, effect of dapagliflozins in the change of estimated GFR in diabetics and non-diabetics had been clear, and that's why the DAPA-CKD had been done on over 4,000 patients, and DAPA with different doses were given 5 and 10 versus the placebo, and had been shown clearly that there was 39 relative risk reduction in the events concerning the renal, estimated GFR to be more than 50% from the baseline in the stage kidney disease or renal cardiovascular death. Besides, the all-cause mortality was declining by 31%. That's why it has been a very supportive treatment for renal patients who are not diabetic, and it has been shown clearly also that dapagliflozin had very beneficial and long-standing effects on the weight up to more than 4 years. And it has also, this shown on the lower diagram or lower graph, but on the upper one you can see that it can keep the A1C declining with sustainability for longer time. And when it had been compared to DDP4s in effectiveness versus DDP4s on the endpoint A1C and body weight and the blood pressure, it had been shown clearly that it has beneficial effects. Besides, its comparison to one of the DDP4s in the Japanese society in a study called the Diversity CVR, it has been shown that patients with cardiometabolic risk factors benefit more with SGLT2 inhibitors rather than DDP4s. Besides, when it has been compared maybe on a lower number of patients, about 470 patients, GLP-1s versus dapagliflozin, it has been shown that they are equally protective, and it's great, but we have to consider the cost issue. And when patients were on combination of dapagliflozin, metformin, and XR, this is very important because the role of the fixed dose combination is very important in improving the adherence and improving the compliance of the treatment. Compliance and adherence are very important for the patients because this enhances the glycemic control and this enhances preventing complications. All those studies had been clearly showing that metformin plus DAPA 5 milligram or metformin plus DAPA 10 milligram can be equally beneficial, maybe variably in the numbers, but all the time there is decline in A1C, all the time there is decline in body weight, and there is the decline in systolic blood pressure, which is an added risk factor for the cardiovascular event. And so this patient was prescribed and added SGL2 for her control of random blood sugar and added control for the blood pressure and cardiovascular problems. But she was scheduled for a cholecystectomy and came back to her cardiologist to ask if it's safe to complete on the DABA metformin. He advised her that she should stop the DABA metformin or even the DABA alone. Definitely metformin has been known before, 3 days before surgery, prior to surgery, and not to be recommenced until all elements of dehydration or any symptoms for ketoacidosis had been elicited and corrected. And we have to educate our patients about the signs of symptoms of diabetic ketoacidosis so that to seek as early as they can medical help. And so to conclude, given that SGL2 inhibitors have potent and highly effective, as shown in the ADA consensus report, their anti-hyperglycemic effectiveness and weight reduction possibilities, also they have cardioprotective and renoprotective properties, and so they can be more tolerable for more time, and they can be given as a best choice for a variant and broader sector of our type 2 diabetes patients. From the start, please don't wait until your patient develops chest pain or his or her estimated GFR decline down from 80 to 60. Thank you so much.